Hi, my name is Rachel Sage McCafferty, and today I'm going to be demonstrating a focused assessment. The very first thing that I would do is to be checking my orders, and after that I'm going to gather all of my supplies. I have personal protective equipment, a stethoscope for auscultating, I have a pen light that I will use to assess the eyes, and a cotton ball to assess light touch, and then a pencil that is dull, but it'll help test whether or not the patient can discriminate between a sharp pain and a dull pain. And then I also have butter knife here that I'm using in place of a hammer to assess the patellar and plantar reflexes. So after gathering all of my supplies, I'm going to wash my hands. Then I will go into the patient's room. I'm going to pull the curtain for privacy, and I'm going to introduce myself. Hi, my name is Sage, and I'm going to be your nurse today. And then I will ID the patient. Can I please have your name and date of birth? And then I will check that with the bracelet to make sure that it's accurate. After identifying the patient, I'm going to explain the procedure and let them know that it's going to take about 20 minutes today. And then I'm going to raise the bed to an appropriate height for assessment. So the very first thing I'm going to do is observe the appearance and behavior of my patient. My patient appears calm. He is alert and awake. He is currently sitting up in bed in a high Fowler's position. His behavior is calm, and he has an appropriate affect. He smiled when I introduced myself. Next, I will assess judgment. I will do this by asking the patient what he would do if his house is on fire. After judgment, I would assess orientation by asking the patient if he knows what time of day it is, where he is, who the president is for person, and then situation, does the patient know why they're here? After orientation, I will assess memory. With memory, I would, for short term, give the patient 3 words at the beginning of the assessment to remember and recall. For long-term memory, I would ask the patient when their last hospitalization was, and this needs to be something that I could verify. And then for immediate recall, I would ask the patient to repeat a phrase after me, and then be able to immediately recall that phrase. Next, it would be attention span that I would assess. I would give the patient a set of directions to follow, and if there was no break in attention span, then that would be good. Next would be cognition. For cognition, does the patient understand what I'm saying, and does the patient answer appropriately? And then speech, does the speech of the patient, is it clear, coherent, and at an appropriate rate and tone? That is the mental status exam. Next, I will assess all the cranial nerves, and by doing that, I'm assessing the neurostatus as well of my patient. So the very first cranial nerve is cranial nerve number 1, olfactory. Before touching the patient, I'm going to apply PPE. So for the olfactory, I'm going to ask the patient to close their eyes, and I have oil of lavender here. I would ask the patient to cover one of their nostrils and to smell. And now I would do this bilaterally, checking the patency of the nose. While I'm assessing the nose, I will use a pen light to inspect to make sure that the nostrils are equal in size. Also, the nostrils are not flaring, so I'm noticing that there's no immediate signs of respiratory distress. The mucous membrane is pink and intact, and there's no excessive mucus. And also, the nose is symmetric to the face. So next, I will assess the optic nerve, which is cranial nerve number 2. I'm going to use my pen light and put my hand in the middle of the patient's face, drawing the pen light inwards, also asking the patient to focus on a distant object, and I'm checking for the pupils to be equal in size, that they react to the light, and that they're round. They should be about 3 to 5 millimeters in size, and that they accommodate the light whenever I'm moving it inwards. Also, while I'm looking at the eyes, I'm going to check for the red reflex by shining the light into the back of their eyes, and there should be a red light that is reflected. And I'm also checking to make sure that that retina is intact and that there aren't any cloudy spots or changes in continuity of the retina. After the second cranial nerve, I will assess cranial nerves 3, 4, and 6. These are the oculomotor, trochlear, and abducens muscles that control eye movement, and I will do this by using the 6 cardinal gazes. I will ask the patient to keep their head still and to follow my pen light with their eyes. I will go up, then down, then right, then left, and then I will do 2 points diagonally. Next is the trigeminal nerve, cranial nerve number 5, and I would assess this nerve by asking the patient to open and close their mouth and clench their jaw. After cranial nerve number 5, there's cranial nerve number 7, and this is the facial nerve. This is looking to assess the facial movement. Can the patient raise their eyebrows? Can they smile? Can they frown? Can they clench their teeth? And or can they show their teeth? I'm also noticing that all of the facial features are symmetric and move equally, and that all of the facial features are symmetric to their face. Next is the acoustic nerve, which is a testing for hearing. And I will do this by using a whisper test. I will ask the patient to cover their opposite ear when I whisper into one ear. I'm going to also put my head behind the patient so they can't see my lips moving. And I would whisper 3 words into that one ear and ask them to recall that, and then I do that on both ears. While I'm here, I'm also going to assess the ears. They are proportionate to the head. I would also need an otoscope to do this, but I do not have one. But by using the otoscope, I'm going to check the ear canal and make sure that there's no excessive cerumen, and that there are no lesions or anything like that. I would shine the cone of light to assess the tympanic membrane, which should be a pearly gray color. And the cone of light should reflect at, this is the right side, it should reflect at 5 o'clock, and on the left side it should reflect at 7 o'clock. I'm also, while I'm here, I'm going to go ahead and assess the head. The head is normal cephalic in size. I'm going to also look in the hair. The hair is thick and evenly distributed. By parting the hair, I'm looking for any lesions or vermin, lacerations, erythema, and I'm not noting that in my patient right now. Also, whenever I'm checking the ears, for an adult, I'm going to pull up, and for a child, I would pull down. After cranial nerve number 7 or 8 was acoustic, cranial nerves 9 and 10 are the glossopharyngeal and the vagus nerves. I'm going to ask the patient to open their mouth and say ah. I'm checking to make sure that the uvula is midline and that it and the soft palate rose whenever the patient said ah. While the patient has their mouth open, I'm also looking at the gingiva, that they're not red or bleeding, and that the membranes of the mouth are pink and moist, that the lips are pink and moist, that they aren't dry or cracking. And I'm also looking at the dentation. Are the teeth straight? Are they clean? Are there any missing or loose teeth? And then, so after cranial nerves 9 and 10 would be the spinal accessory nerve, cranial nerve number 11. I'm going to assess this by putting my hands on the patient's shoulders and asking them to shrug and not let me press down. And finally would be the hypoglossal nerve, cranial nerve number 12. And I would ask the patient to protrude their tongue and say light, tight, and dynamite. Next, I will assess the throat. Since I already was at the head, I'm going to stand behind the patient and I'm going to palpate for the thyroid. Whether or not it's palpable, I'm going to also make sure that the trachea is midline and easily displaced, and that there's no crepitus or rigidity in the trachea either. I would also assess, I'm looking at the neck and there's no erythema. As I'm palpating, noting any tenderness, and I'm also going to check the lymph nodes. So for the lymph nodes, I would be moving in a circular motion. I'm assessing for any tenderness. The lymph nodes should not be hard. They should be easily displaceable. And yes, so we have the preauricular lymph nodes, posterior auricular lymph nodes, submental, submandibular, jugulodigastric, and when I'm palpating jugulodigastric, I will ask the patient to open and close their mouth and clench their jaw, and that would be assessing the temporomandibular joint, noting any crepitus or tenderness or anything that would be abnormal with that joint movement. After jugulodigastric, we would have superficial cervical, and then we have the deep cervical chain, posterior cervical, and supraclavicular. And those are all the lymph nodes in the head. While I'm at the neck too, I would assess the carotid pulse. That is here, and I would do this bilaterally, but one at a time as to not instigate syncope. And then while I'm doing peripheral pulse points, I'm checking the brachial, and I'm doing all of these bilaterally, the radial, and then the femoral, popliteal behind the knee, dorsalis pedis, which is on the top of the foot, and then posterior tibial, which is on the medial ankle. And while I was checking the posterior tibial, I'm also assessing for any edema. I'm checking around the ankles, and there should be no pitting. While I was doing the peripheral pulse points, I was assessing for pain, pallor, paresthesia, and paralysis. And next, I would move into musculoskeletal. I would assess range of motion and strength in all extremities and in all joints, and I would do that bilaterally. And I, for example, would ask the patient to abduct their arm, to adduct their arm, and to circumvent their arm. And then for assessing strength, for example, I would have the patient grip my fingers and squeeze. So that would be that. While I'm here as well, checking peripheral vascular and neurovascular, I'm asking the patient if they can feel this light touch. I'm also noting whenever I'm palpating all the extremities that they're all warm bilaterally, and that the patient, assessing the skin, that there isn't any sweating or dryness of the skin. I'm always looking for masses, nodules, lacerations, ulcers. So after assessing light touch, I'd ask the patient if they could discriminate between a dull and a sharp pain by doing this. And I could also assess temperature sensation by using a cold pack and seeing if they could feel cold temperature. I can assess the patellar and plantar reflexes. For patellar, I'd ask them to sit on the bed, and I would have their feet dangling, and I would hit under their kneecap. And if that was normal, that would be a +2 rating. Then for the plantar reflex, I'm assessing for a Babinski. I would take the end of the hammer and draw it up the foot and inwards. And the toes should fan in or curl in. That would be an indication of a negative Babinski sign. A positive Babinski sign would be if their toes flared, and that is only normal up to 6 months of age. While assessing musculoskeletal, I would check their gait. I would ask them to do a heel to toe walk, and the gait should be steady. I would also do a Romberg's test by having the patient stand, and I would put my hands in front and behind them while doing this to prevent a fall or to assist them to the ground if necessary. But I would have the patient close their eyes, and if they were able to stand without losing their balance, that would be great. I would also assess rapid movement by having the patient flip their hands like this. While I'm here, I can assess the nails. I'm checking capillary refill, which should be less than 3 seconds. And I'm doing this on both hands, both feet. Checked edema. I'm also looking at the nails and making sure that they're not brittle. And the nail bed should be pink and the nails should be translucent. I'm checking for cleanliness of the nails, whether or not they're trim or smooth. I'm also checking for clubbing. I would do this by having the patient put their thumbs together back to back, and I'm looking for a diamond shape. Next, I will assess the respiratory. I'm only going to uncover the patient as much as is necessary for this examination. Since I'm not doing focus assessment on respiratory, I wouldn't have to, well, I would auscultate 5 areas in the front and 9 areas in the back. I am checking for adventitious lung sounds, any wheezes, rales, or bronchi. I'm also looking at the chest to make sure that it rises equally when the patient inspires. I am looking at the chest, palpating for any nodules or masses, or areas of tenderness. So this would go into me assessing the heart as well. When I'm assessing, when I'm doing a cardio assessment, I am inspecting the chest to make sure I'm looking for scars. I'm also looking for any erythema, lacerations, and I'm palpating for masses and nodules. When I auscultate the heart, I'm going to auscultate in 5 areas, and the first area is the aortic area, which is on the right second intercostal space. And in the aortic area, you should hear S2 the loudest, and S2 is the sound of the semilunar valves closing. After listening to the aortic area, I would listen to the pulmonic area, which is in the second left intercostal space. Next would be Erb's point in the third intercostal space on the left side, and this is where I can hear S1 and S2 together, the clearest. After Erb's point would be the tricuspid area, which would be in the fourth intercostal space, and on the left side, and then after the tricuspid area would be the mitral area, which is in the fifth intercostal space, medial to the clavicular line. And in the mitral area is where I can hear S1 the loudest, and that is the sound of the atrioventricular valves closing. While I'm listening to the heart, I'm listening for any murmurs, extra beats, irregular beats. I'm also noting the rate rhythm of the heartbeat, and I will also note that the apex of the heart is in the the apex of the heart is in the fifth intercostal space at the mid-clavicular line. And if the pulse was irregular, I would listen to the apical pulse for a full minute. While we're doing the chest as well, I would also assess the AP diameter, making sure that it is 2 to 1. Then I would do an abdominal assessment very quickly, as this is not the part of the focused assessment, but I would uncover the abdomen, and I would be looking for any hernias, any protrusions, scars, striae. I would first listen in the right lower quadrant, and then I would move to the right upper quadrant, then the left upper quadrant, and then so right lower, right upper, left lower. I'm listening for at least a minute in each of these quadrants to note bowel sounds, whether or not they're hyperactive or hypoactive. And if I do not hear any bowel sounds, then I would need to listen for a full 5 minutes on each quadrant. So also I need to assess skin turgor. I would do this by pinching the patient's skin, and it should immediately recoil back to place, and this is testing for hydration. And then I also, while I was listening to the lungs, in the back, I could have assessed the costovertebral angle, and I'm palpating for tenderness. This area should not be tender. So that finishes our assessments today. I would return the bed to its lowest position. I would assess for further client needs, whether or not they needed anything to drink, or in general, just if they needed anything at the moment. I'm going to make sure that their call light is in reach. I'm going to let them know when they can expect me to return. And I'm going to remove my PPE. I'm going to wash any equipment that touched the patient. I'm going to thank the patient. And lastly, I would document. Thank you very much for watching today.